Today's topic is vast. Since what is there? Physiological variation in waveforms, abnormal waveforms, different waves, their interval segments, they are having normal values. So these values are changed in different conditions. So these are the abnormal variations. These values, these wave segments, they can also vary normally physiologically. So that part I am not going to elaborate. But in the PPT you will be getting all these things. And there are other topics, important topics. These are arrhythmias, heart blocks and myocardial infarction. So I will try to confine my elaboration on arrhythmias, heart blocks and myocardial infarction. So since myocardial infarction is much more important, then I will start with myocardial infarction. Myocardial infarction is ischemic heart disease. It results from ischemic heart disease. Ischemic heart disease, in short we call IHD. What is this? It is a group of pathological clinical conditions, syndromes, which are resulted from inadequate blood supply. Results from inadequate blood supply, not oxygen. Inadequate blood supply. If there is inadequate blood supply, automatically there will be inadequate supply of oxygen. It is obvious. Not only this, there will be inadequate removal of the waste products. When there will be inadequate supply of oxygen, the tissue will change its metabolism from aerobic pathway to anaerobic pathway. As a result, some metabolites will be formed. These are harmful locally. So this has to be waste. It has to be removed. But if circulation is reduced, then how this will be? This will not be properly eliminated from the site. So it will cause some changes in the myocardium. Okay. So it is inadequate supply or subsequently oxygen supply to a part of myocardium. It may be due to reduced oxygen supply or increased demand for oxygen. Suppose in the periphery lot of resistance is there. So heart has to work more. So here what is happening? Lot of oxygen demand will be more to perform its work. So as a result, if the oxygen is not supplied, blood is not supplied to the myocardium according to the demand, then it will suffer what? Ischemia. Okay, now if this ischemic changes, ischemia is there continues for some time, then myocardial cells, the effect of the affected area, they are going to die. Means death, there will be death. It is called also necrosis. So while the anemia to hypoxia to necrosis, these stages, there may be several changes, and these will changes in the myocardial cell, their function, their electrical activity. As a result, its consequence may be reflected in the electrocardiographic waves, particularly in the ST segment, particularly in the T waves, okay, particularly in the Q waves. So here in such diseases, we will focus our attention, will remain on ECG waves. Which ECG waves? Particularly on the ST segments. You know what is the ST segment? It remains usually in the isoelectric line. It may be elevated, it may be decreased. So we'll see. So our attention, our focus will be on what? ST segment, on T wave and appearance of Q wave. Q wave is called widowmaker. What? Widowmaker means this disease actually happens in older age patient, more than 40 years of age. So they are married. So when we find the QA, that is the cells as necrosed. Myocardial cells are necrosed, and if it occurs in a large area, the patient is going to die, and his wife is going to be a widow. So that's why it is called a widow maker also. So you try to remember this. Okay. So you can see this is the oxygen demand, it is oxygen supply. If it is disbalanced, then what will happen? There will be lack of oxygen supply, means lack of blood supply. And why the blood sulfur will be reduced? What are the reasons? The reasons may be many. Many, not so many, but number one is narrowing of the coronary arteries. We know coronary arteries are narrowed during systole, isn't it? That's why what happens, supply is to the myocardium, blood supply is reduced, because these vessels are compressed. The lumens are narrowed. As a result, which part will be affected most? The innermost layer. We placed one question, in examination. Why the innermost layer? What is the name of this innermost layer? Endothelial layer. Endocardium. So this endocardial cells will suffer first. And they will suffer first ischemia. And if it continues, these cells will be first infarcted. Means myocardial infarction, it happens. First, where it will happen? In endocardium. Okay. And not only because of this, the vessels can be narrowed by another important means, that is presence of atherosclerotic plaque, also called atheroma. So we'll see how this atheroma is formed. There is a pathological steps, processes, by which we'll see how these plaques, how this atherosclerosis is formed. We know that there is bad cholesterol. They have got some role here. So what role this bad cholesterol perform? So we'll see that. Okay. So this is narrowing of the blood vessels, and atherosclerosis, that is the atheroma. What is atheroma? Fibrofatty plaque in the coronary blood vessel. There are two types of plaques. One is stable, another is unstable. These unstable plaques are dangerous. These unstables are very dangerous. Why this? The stable plaques, they gradually grow. The stable plaques, I'll show you the picture. So this is the innermost layer. So here, plaque is formed. And this plaque contains so many things. At the center there is fats. Not only this, there are fibrous cells, there is fibrous coating is there, fibrous cell coating is there. There is macrophages, foam cells. Actually, why it happens? Why this atheroma or atherosclerotic plaque forms? They are formed because of injury to the endothelium. What makes it injured? One is smoking, cigarette smoking, hypertension, like that. There are these type of factors. They actually injures the endothelium. Because of injury, this injury initiates the process of formation of atherosclerotic plaque. So first, what will be there? There will be accumulation of cholesterol. Accumulation of low density lipoprotein, which is called bad cholesterol. So this will be accumulated there. When these are accumulated, there will be some sort of inflammation. As a result, macrophages will be coming here, monocytes will be coming to this place, and they will engulf, these macrophages will engulf this cholesterol. As a result, what will be? It will be transformed into foam cells. Now these foam cells are having lot of fats. These fats, they have engulfed it. So there will be lot of foam cells. Now some muscle cells will appear over this. Some fibrous cells will appear over this. And a coating will be formed. Fibrous coating will be formed. Fibrous plaque will be formed. And this fibrous plaque is dangerous if it is removed. If it is removed, it can be removed from where? I said there are two types of atheroma. One is stable, another is unstable. The unstables are usually prone to dislodge, prone to be broken. If they are broken, when they are broken, this layer is made up of also collagen fibers. We know, we have seen when we have studied mechanism of coagulation. Okay, in that state, when blood cells are injured, collagens from the blood vessel, collagens are exposed. Collagens are constituent of the wall. These are exposed. Now this collagen attracts platelets. So if they are exposed, collagen will be exposed. Fiber will come out in the surface. Now they will attract the platelets. So lot of platelets will be coming there and they will be stacked together. They will be stacked there. Platelet accumulation, platelet aggregation, platelet plaque formation will be there. And not only this, fibrin, soluble fibrin will become, by this time some factors will be released, they will convert fibrinogen into insoluble fibrin, then it will be made insoluble, and this insoluble fibrin will cover the platelets. Okay, there will be a tight plug will be formed. Now, what is there? These are forming here. As a result, what is this? This lumen is narrowed. Blood supply will be reduced. And when it may cause complete blockage, infarction will be there. When there is complete blockage, there will be infarction. And not only this, these are also having blood supply. These are having blood supply. Now this blood supply can cause hemorrhage within the disc. As a result, it will be swelled. There will be swelling. And because of this, the cell, there may be fissure. There may be fissure. As a result, this collagen will be exposed. Now platelets will be adhered. And this platelet plug will be formed. It will be reduced. Not only this may become fragment. This topmost layer, may be plaqued off. And what will happen? When these are plaqued along with blood, they will be moving forward. And ultimately it will be blocking a narrower vessels. So that vessel is supplying some myocardium. So that myocardium is going to be ischemic necrosed because of occlusion. So this is the process of formation of this plaque. Okay, I briefed it in detail. You will find it in my PPT. Okay, next see, this is one of the cause of reduction in blood supply. Another cause is spasm. Another cause is plasm. Another cause, atherosclerosis is made here. Okay, here is the atherosclerosis. Here, from here, some plaque is formed. Now they will be circulated throughout the body, and they will also enter into the coronary arteries, and they are going to block. These are called embolas. So embolas may be formed, and they also can block the coronary arteries, branches of the coronary arteries. They can occlude the lumen. That way ischemia may be developed. When this ischemia progresses, and there will be finally total occlusion of the vessel, then what will happen to the cell? The cell will be going to die necrosed. So during this process, if ECG, I said this is from the starting of low supply of oxygen, low supply of blood, some functional changes in the myocardium, electrical changes is taking place, and these are going to reflect in the ECG morphology, particularly of ST segment, T wave, and Q wave is going to be changed. So we will notice how these are going to be changed. So these are the atherosclerotic plaque formation. I have already in short I told. So this is the thrombus formation. So this is the thromboplatelet accumulation, bleeding. From here bleeding can be made, and this will be clotted, and this thrombus will be formed. Now this thrombus can totally block the lumen, and also if it is fragmented, this may form embolus, and distant blood vessels can be blocked by this. Okay, now let us discuss about what are the different types of ISD. ISD is, we can classify them when blood supply is narrowed, so only there is, the cells are feeling hypoxia. Only lack of oxygen supply is there. Blood supply is not totally blocked, but reduced. So in this condition, there will be angina pectoris. You know what is angina? I think you have repeatedly learned about this, or you have heard about this. And I will also discuss this angina pectoris may be of two types. It is stable, unstable. Unstable means the angina pain is there after taking rest or taking nitroglycerate, sorbitol, it goes there. There will be vasodilatation, more supply to the myocardium, more supply of blood to the myocardium, so it will be okay. Okay, so it can be reversed when rest is given. Okay, but if it is not reversed, then it is going to be stable. If it is stable, this stable angina can proceed to myocardial infarction, because there will be ultimately total blockage, and when there is total blockage, there will be infarction, death of the myocyte of that area. Okay, so this angina pectoris, which are unstable, these are of short duration. If it is long duration, then it is serious. Okay, what is the next type? MI, myocardial infarction, and other one is sudden cardiac death. You don't have any scope. When it happened, patient died. Large area involved. Large area is involved. As a result, the patient died. When right coronary artery, left coronary, major two arteries, any one is blocked. Or simultaneously, both of them are blocked. So, patient will die instantly. So, this is sudden cardiac death. And another is chronic MI. So, if someone, you have seen some patients are there who have suffered previously they have suffered this MI, they have suffered, but they survived, but their ECG made a permanent change. By seeing this is the Q wave. Whenever you see this abnormal Q wave, normally it is not present in such leads, but in such case it is present. That means this patient has had previously heart attack. So it is the healed, repaired by the fibrous tissue. This tissue, we know, whenever it cut, some tissues are damaged, died. Now these tissues are damaged, replaced by fibrotic cells, fibrous cells. So here also in the heart, in lung, because of tuberculosis, some lung tissues are damaged. So they are replaced by fibrotic cells, but they are non-functional. Only they are just covering the area. Okay, but they are not functional. They will not be performing the function of lung. They will not be performing the contractile activity of the arm. Anyway, so these are the different types of ISD. So, coronary, this is stable, unstable, and myocardial infarction is again of two types. One is STEMI, another is non-STEMI or non-STEMI. What is STEMI? ST segment, ST money, ST segment, E for elevation. If in myocardial infarction, ST segment is elevated, that will be termed as STEMI. ST elevation myocardial infarction, and in such case there will not be any ST elevation. So it is non-STEMI, means non-ST segment. Other changes will be, T wave will be changed. Okay, so other changes will be there. So we will see the changes in T wave. Other changes will be there. So that is and STEMI. We will tell you how to identify and STEMI, how to identify STEMI. And sudden cardiac death we have seen. So how these are formed? No ST elevation, ST elevation. So it may develop U wave myocardial infection. But if it is not, then non-Q means cardiac cell is not died. These are still alive. Okay. And no ST elevation, this will be, but ST depression may be there. So because of ST depression, we can diagnose them as what is this, ischemia, but it is unstable. Okay. So MI, what is MI? What is MI? See the definition. It is the condition when an area of the cardiac muscle, area of the cardiac muscle, heart wall is necrosed due to permanent arrest of blood supply from coronary blood vessels to that area. So permanent arrest, it is essential. Permanent total closure, total occlusion should be there. Then they will be necrosed. Otherwise not. Okay. So there will be the cause of arrest of the blood vessel, blood supply to the formation of thrombus. Due to the formation of thrombus. Why it is arrested? Blood supply because the formation of the thrombus. Okay. And in a region narrowed by atherosclerotic plaques. So this is the definition of MI. Now acute MI. So International Group Association of Cardiologists, they defined MI as that is acute MI as a clinical event consequent to the death of cardiac myocytes that is caused by ischemia. Why ischemia caused? Why? We have already explained. Okay. Now what are the symptoms of MI? This is important. It is like the symptoms of angina. But in case of MI, myocardial infarction attack, heart attack, the symptoms are more severe and they are permanent. They are not going to be relieved by the rest or by nitroglycerin, sorbitrate, this vasodilators drug. So what are these? The pain. First one thing is pain, diffuse pain. Okay, the pain may be diffusing, constricting pain, heaviness on the chest, something cramping pain, chest tightness, heaviness, and burning. It can be a sense of burning in the chest or like a clenched fist. Clenched fist in the chest. So these are the pain types where you will find where this pain will be radiating to the neck, to the jaws, to the shoulder, to the arm, particularly to the left arm, in the abdomen. So there these pains will be referred, will be radiated. Okay, so these are the pain type, pain areas. Now there will be autonomic upset, and because of this, even in winter, even in cold climate, there will be sweating. There will be sweating, cold, it is called cold sweating. Normally, normal sweating may also cold sweating, and these hands, limbs will be cold. You will feel these cold limbs. Okay, this can happen, and sweating, palpitation. There will be palpitation, increased heart rate, tachycardia may be there, tremor. There may be tremor. Clammy is the coldness of the limbs. Shortness of breath means dyspnea may be there. Nausea, vomiting, lightheadedness, and dizziness, anxiety, fatigue. These are the some common features, common symptoms of myocardial infarction. Remember one thing. Though I am telling these are the signs, symptoms of ischemia infarction, there may be heart attack, but your ECG may be normal. So always don't depend on ECG findings. So there are some markers, cardiac markers. If the cells are damaged, some enzymes will be coming out in the blood. Within 24 hours, their level will rise. After 24 hours, they will be coming to normal. So as soon as possible, you like troponin A, myoglobin. So these are some markers. Trop T, Trop C. So these are some markers. Okay, LDAs. So these are the markers. So this marker are supported by ECG findings. Then you will confirm. Okay. So if ECG findings are normal, so don't ignore that patient is not suffering from this, but then immediately go for markers to confirm. Okay. Now, see, we have said this is the subendothelial layer. Subendothelial layer, and this is the epicardium, and this is the epicardium, subendothelium. So what is there? The blood. This is the main artery. So this is supplying the myocardium. From here, some branches is coming to the subendocardial layer. So when they are contracted, during diastole, systole, what happens? These vessels are constricted. These vessels are compressed. Even the smaller vessels, they are compressed. As a result, what happens? There will be less supply of oxygen to the subendocardial layer, to the subendocardium. So they will suffer lack of supply of oxygen. If it continues, they will suffer infarction. Okay. And see, this area is involved. Subendothelial layer is involved. They are necrosed. They are ischemic. This is the non-ischemic region. This is the ischemic region. So this area is feeling ischemia for different reasons. One is because of this, and another is formation of atherosclerotic plaques here in the blood vessels. In the blood vessels, in this blood vessel, atherosclerotic plaque, as a result, less blood supply will be there. So they will supply there will be lack of or less perfusion, means less oxygen supply, or less removal of wastes. And when this area will increase up to the whole wall, this will be termed as not subendothelial, not the subendocardial. Now it is transmural MI. What is transmural MI? When whole of the myocardium, whole whole wall thickness is involved, then it is called transmural MI. Is that clear to you? Okay, transmural and subend. So first there will be MI in subendocardial layer, and when it continues, then it will affect the whole thickness. Now it is transmural MI. Progression. How it is progressed? Ischemia to infarction. What happens? Narrowing of the blood vessel, whatever that means. Okay. Now there will be subendocardial ischemia. Okay. If not reversed, not relieved, then what is prolongation of subendocardial ischemia, and further narrowing of by this time there will be further narrowing of the blood vessels. Blood vessel narrowing is continuously going increasing, narrowing. Development of subendocardial infarction and necrosis of the affected subendocardial cell. So already one portion is necrosed. So there is infarction. with time prolongation, there will be constriction of the further constriction of the blood vessels of the affected area. So there will be partial transmural ischemia. Only a part of the transmural region will be affected. When it really continues, then there will be total blockage. When there will be total blockage of that particular concerned blood vessel, there will be involvement of the full thickness of transmural ischemia. And when it is there, when there is full, it is there, though totally constricted, the cell is not dying. So what is happening? This is called hyperacute stage. Hyperacute stage of MI. Then there will be this stage, acute stage. And after that, evolved state means by this time Q wave appeared. Q wave appeared means the cells are died. Okay. So if patient survives, this is STEMI, ST segment will be elevation will be there. So when the patient survives, they will be termed as chronic MI. So these are the steps how progression of ischemia into infarction. ECG features of myocardial ischemia that may, not sure, that may be MI. What is this? New. Previously the person's previous ECG did not reveal any ST elevation. But now, at present, I am seeing there is ST elevation. How much elevation? 0.2 millimeter in leads B1, B2, B3. And in all other leads, it is not 0.2, it is even less. 0.1 means 1 millimeter. 0.1 means from the elevation, from the baseline, only 1 millimeter above. So it is ST elevation. Absence of ST elevation, in absence of ST elevation, no ST elevation, but either ST depression or T-wave abnormality, T-wave inversion. So that is non-STEMI. So in non-STEMI, there will not be any ST elevation. There may be ST depression. There may be abnormalities in the T-wave, not in Q-wave. Okay, so it is non-STEMI. Okay, so phases of MI. Phase, see the phase. Hyperacute phase. It happened just, I am just having the attack. So from this time, 2 hours, hyperacute, this will be a few hours, it will be recommended, it will be termed as hyperacute. If you perform an ECG during this time, you will find a tall T wave, wide and tall T wave. Usually these are not so much tall. Okay, so that will indicate acute phase. Okay, then evolved phase. The hyperacute phase. Okay, then comes the acute phase. First hours, 1 or 2 or 3 hours. This is the acute phase. You will see ST elevation will be there. Type of elevation. And here, evolved phase, hours to days. Here, type of elevation is changing. Okay, and in the chronic phase, this is the changing, and the Q wave will be formed. And we'll see how the ST segment is changing. Then chronic stage means it is here, it may take months to years. So main ECG changes, ST segment elevation, how much? Greater than 1 millimeter, and storm stoning means ST segment will coming and going from it to the top portion is rounded like this. So it is called storm stoning. Storm stoning, T inversion, abnormal Q wave, ST depression in reciprocal reeds. Remember, I said reciprocal reeds. I will explain what is reciprocal. This is important. You are getting both. What? ST elevation as well as ST depression. What does it mean? Some side is having ischemia and some side is infection. No. So when one side is having ST elevation, the reciprocal leads will also reflect the same thing, but by ST depression. ST depression. Okay. So this has to be remembered. Okay, acute phase, these are the different. So what is ST segment elevation, T inversion, abnormal Q wave, and ST depression in reciprocal leads. So what are these points? Remember, write down these points. One is ST segment elevation and T wave inversion, abnormal Q wave, ST depression in reciprocal leads. So these are the points you have to see. Whenever you will find an ECG, you will look for whether these are there. Elevation. So in B1 to B3, it should be more than 2 millimeter. In other leads, it is limb leads or precordial leads. Precordial is B2, B6 should be more than 1 millimeter. And C, evolution of stemming. Normal, deep T wave. This is hyperacute state. This is hyperacute. Deep, normally it is like this. Now it has gone up. So this is hyperacute. Then there will be ST segment elevation. So see, it is not coming to the baseline. So this segment is elevated. This segment is elevated. Okay. Here, when it progresses, what is there? This is moved upward. It may become coming here, there, and become the horizontal. We see it will become horizontal. Then appearance of Q wave. So you have started coming. So here, what is happened? This is further coming. It's coming to normal. Patient is recovering. Okay, it is coming. This will be ultimately coming to this line. It has came to after some time, some days or some months. It is coming to this, and T wave inversion was there. Again, T is upright. So in this way, it progresses. But Q wave retains. This Q wave will not go. It will persist. So whenever you will find, as I said, the patient is having only abnormalities deep Q, that means the patient had heart attack previously. So these are the different types of ST segment. Which domain, tom stoning, this is tom stoning. Okay, this is straight, going straight, obliquely, and it is becoming horizontal, it is down sloping. This sort of ST segment elevation may be there. So these are the variant of ST segment, and it develops with the progress of ischemia. With the progress of ischemia, this pattern will also be changed. And hyperacute state, as I said, this is hyperacute state, hyperacute MI. So see the T waves. See the T waves. Okay. So these are long Q waves. Yeah, T waves. And acute MI, first hours. In first hour, what will the ST segment elevation will there? Indicate transmural injury. Full thickness of myocardium, localized to leads, reflecting the affected myocardial area. Okay, so suppose in the lateral layer, here, the lateral layer. So some leads are there, that is seeing the heart from this side, B5, B6. So these will be present there. And their reciprocal leads, they will show ST, not elevation, ST depression. Opposite thing, ST depression will be there. So ST elevation more than 1 millimeter in the 2 or more contiguous leads. 2 or more what are contiguous leads? Suppose lead 1 or say lead 2. Where is the positive pole? Here. And lead 3 here. Where is the positive? Here. So these two leads looking at my heart from the bottom, from the inferior surface. So here, if we find the change in these leads, that what change? This type of change, that means inferior aspect of the heart is affected. this infarcted area is in that area. Okay, and its opposite side, here the lead one, it is the reciprocal lead. So there in that reciprocal lead, you will get ST depression. Okay. In STEMI, see, myocardial, this is ST elevation, and I don't have so much time. So if you can see, ST elevation, and what are these? Before, these are the lateral wall myocardial infarction. Okay. Evolve phase now, where there is total obliteration, total blockage, Q wave will appear. So you will find deep Q wave. Duration, Q wave duration 0.04 means 1 mm, and it may be 1/4 of the R wave. In that you see the R wave, and it should be 1/4 of the minimum 1/4 of the R wave. Indicates myocardial ischemia seen after it starts to resolve. Yes, in this, okay, chronic phase there will be persistent, all other waves will coming to the normal except the Q wave. Then there is a chronic stage. So how this is developed? Gradual progression. Okay, you have seen, is that okay to you? Could you follow this? Okay. Now, one important. You have seen this. Now we have to find out where this infarction taken place, in which area of the heart. You have to localize the infarction. You have to localize the infarction. How you will localize? So for that purpose, we have ECG leads. We know these leads. These are the chest leads. B1, B2, B6, B5, B4, B3, B2, B1. Okay. So this is the heart. You are looking at the heart horizontally from front to lateral. And these leads, 2, 3 AVF, they are looking at the heart from the bottom. Means inferior aspect of the heart. So if these leads are, if you find those changes in these leads, that means it is inferior wall ischemia, inferior wall infarction. If you find in B1 and B2, since they are facing the septum, interventricular septum, this means infarction is in the septal wall. And B3, B4, they are looking at the front. That means anterior surface of the wall, heart. So in this case, B3 and B4, sometimes B2 may be involved. B2, B3, B4. Or if you get the changes only in this, that is only anterior wall involved. So, lateral wall, this wall, B5, B6, plus, what are these? These two leads, 1 and AVL. Here also you will get the change. Okay? So this is important. Get this copy of this. B1 and B2 facing the septum. B3, B4 anterior wall. Changes in B1, B2, B3, B4 means anteroseptal. B1, B2 septal and B3, B4 enter. That means both anterior surface as well as septum is involved. See in this? And they don't have any reciprocal leads. They are opposite side leads. And lateral wall. Lateral wall means B5, B6. As I said, looking at from this side, B5, B6, lateral wall. Moreover, lead 1, positive side is here. Lead 1 positive, so it is looking at from the lateral side. ABL, it is also positive plate, it is here. So it is also looking at the lateral surface. So A1, ABL, B5, B6. and it is reciprocal. That means if ST elevation, T wave, whatever you get, this ST elevation is there, in reciprocal, this leads you will get ST depression. Here you will get ST depression. Okay. Similarly, for anterolateral, these are the leads that are facing to the anterolateral. Its reciprocal leads are 2, 3 AVF. Here you will get ST elevation, here you will get ST depression. Remember this thing, this is important. So while you will be identifying, you just where you can, which are the leads involved, where ST elevation is there, so mark it. ST elevation is seen in this and this, ST depression. Now localize from the earlier part, localize the area. If the changes is there in the reciprocal leads, opposite changes, depression is there, so it is confirmed. Okay, so in that way, you can not only this area, now whose coronary artery is involved? Where, whose coronary artery, coronary circulation, some artery, there is occlusion of some coronary, which artery? So this also you can see. ST elevation in these leads, left circumflex artery. Blockage is there. If it is here, right coronary artery. If it is in the here, left anterior descending artery, widowmaker. So these are some for diagnostic purpose. So whether you are able to find out, so that's why some tracings are given, whether you learnt it or not. So this ECG is given. See, some ST elevation is there. We can see elevations is there. So corresponding depression is there. So from this you have to localize which area is involved, which blood vessels is involved. Non-STEMI already I told. So this is in case of non-STEMI. So there will be depression, no ST elevation. No ST elevation, only depression. Okay, so these are the depression, okay, and in case of STEMI, there will be elevation. This is STEMI, these are N-STEMI. T wave inversion, say here T wave is positive and gradually it may develop. These are some examples. These are ST depression, ST segment depression, upsloping, not so serious. This is very serious condition. This is when downsloping, very serious condition. When a person having normal person running on a treadmill, stress ECG is being done. So at that time, while ECG is going, if you notice this ST segment depression, that means the test is positive. Test is positive for stress test. That means there is some blockage. And now he has to undergo angiography, and the location angiography will locate the where in which artery is involved and where it is. Then by angioplasty, this blockage will be removed. So these are the first ECG, then stress ECG, okay, then angiography, angioplasty. Nowadays bypass surgery is not done, so angioplasty is the choice. Okay, now I thought of at least blocks. One is hexaaxial reference system, important. That day I couldn't cover hexaaxial reference system. If you take this, everything is there. Abnormal ECG pattern, and there is different arrhythmias. What are arrhythmias? I want to show this. This is so arrhythmia. I'll take 2 minutes. Arrhythmia, what is arrhythmia? No rhythm. There is no rhythm. There is no normal rhythm. Means heart is either beating fast or it is beating slowly or irregularly. Beating fast, more than normal, it is means tachycardia. It is also arrhythmia. Bradycardia, it is also arrhythmia. And irregular beating, it is also arrhythmia. Now it may be classified bradyarrhythmia into and tachyarrhythmia. Okay, so normal Heartbeat 60 to 100, we know this. And bradyarrhythmia means this. Mild bradyarrhythmia, 20 to heart rate, 20 to 40. And beats per minute, M is missing. And severe bradyarrhythmia, oh my God, 15 to 20. This zero will not be there. So this zero will not be there. Why? Actually, yesterday night I did it. So there was mistake that at around 1 p.m. So 1 a.m. So that's why this mistake. So and in case of tachyarrhythmia, when heartbeat is 150 to 250 increased, it will go paroxysmal tachyarrhythmia. When heartbeat is between these two days, this is flutter. This, for example, this is important. What is atrial flutter? What is atrial fibrillation? What is ventricular fibrillation? This usually comes in exam. So you have to know this. But today is the last class for CVS. So here I don't have any scope. Next class, my next class is on renal system. So for better understanding, you please, for yourself, think about your result. So study. When I start, before that you try to, what is the topic you will be knowing. So initial 2 classes are very easy class. So if you go through for once, you will be knowing it. Arrhythmia actually why happens? It happens due to automaticity. We know our cardiac muscle has got automaticity. So this automaticity is may be influenced by the nervous system hormones. So they can increase, decrease the heart rate. So that is arrhythmia. So by altering the automaticity, by altering the conductivity, as a note, we know a path is followed. If there is any path disturbance, block, say for example RBB, LBB, or delay in PR interval, longer, there may be a first degree AV block, or all the cardiac impulses are not passing, coming to the ventricle. Some are coming, some are missing. So these are what? These are arrhythmia. So there are different first degree, second degree, third degree. So there are three different degrees. So try to, everything is there in the PPT. I think everything is covered nicely, so you go through it.